This recording will go over methylxanthines and leukotriene modifiers. Methylxanthine derivatives are a major group of bronchodilators. Xanthines stimulate the central nervous system and respiration, dilate coronary and pulmonary vessels, and cause diuresis. Because of their effects on respiration and pulmonary vessels, xanthines are used to treat asthma. Your prototype xanthine derivative is theophylline. Theophylline relaxes the smooth muscle of the bronchi, bronchioles, and pulmonary blood vessels by inhibiting the enzyme phosphodiesterase, resulting in an increase in cAMP, which promotes bronchodilation. So again, theophylline, a xanthine derivative, works by increasing the amount of cAMP, and you already know that cAMP equals bronchodilation. Theophylline has a low therapeutic index and narrow desired therapeutic range of 5 to 15. The serum levels of theophylline should be monitored frequently to avoid severe adverse effects. Toxicity is likely to occur when the serum level is greater than 20. Because of its numerous adverse reactions, drug-to-drug interactions, and narrow therapeutic drug range, theophylline is prescribed mostly for maintenance therapy in patients with chronic, stable asthma or other COPDs when other drugs have failed to show improvement. Theophylline drugs are not prescribed for patients with seizure disorders or cardiac, renal, or liver disease. Side effects and adverse reactions to theophylline include anorexia, nausea and vomiting, gastric pain caused by increased gastric acid secretion, intestinal bleeding, nervousness, dizziness, headache, irritability, cardiac dysrhythmias, tachycardia, palpitation, marked hypotension, hyperreflexia, and seizures. Adverse CNS reactions ranging from headaches to insomnia, nervousness, and seizures are often more severe in children than adults. Theophylline can cause hyperglycemia, decreased clotting time, and rarely increased white blood cell count, leukocytosis. Because of the diuretic effects of xanthines, including theophylline, patients should avoid caffeinated products such as coffee, tea, cola, and chocolate, and they should increase fluid intake while taking theophylline. Theophylline increases the risk of digitalis toxicity and decreases the effects of lithium. Beta blockers decrease the liver metabolism rate and increase the half-life effects of theophylline. Phenytoin decreases theophylline levels. Please review the purple nursing process box on bronchodilators on your own and take notes. Leukotriene is a chemical mediator that causes inflammatory changes in the lungs. Leukotriene modifiers are effective in reducing the inflammatory symptoms of asthma triggered by allergic and environmental stimuli. These drugs are not recommended for the treatment of acute asthmatic attacks. Your prototype leukotriene modifier is montelukast. Montelukast is used for the treatment of allergic rhinitis and asthma and for exercise-induced bronchospasm prophylaxis. It works by binding with the leukotriene receptors to inhibit smooth muscle contraction and bronchoconstriction. Leukotriene receptor antagonists and synthesis inhibitors should not be used during acute asthmatic attacks. They are only for prophylactic and maintenance drug therapy for chronic asthma. Go ahead and pause the video to review the purple nursing process box on leukotriene receptor antagonists on your own, and then resume the video to see if we pulled out the same important information. So in terms of assessment, we'll want to get a good history, medical, drug history, supplements, everything they're taking. We want to get baseline vitals. We want to assess lung sounds for any wheezing, decreased breath sounds, cough, or sputum. We want to assess sensorium for confusion and restlessness caused by hypoxia or hypercapnia. We want to also determine hydration status. Nursing diagnosis are related to airway, so airway clearance or gas exchange would be priorities there. In terms of planning, the patient will be free from wheezing or wheezing will have significantly improved. The patient's lung fields will be clear within 2 to 5 days. The patient will take medications as prescribed. And I would add in there the patient's O2 saturation is within desired limits or ranges. In terms of nursing interventions, again, we're going to monitor respirations for rate, depth, rhythm and type, monitor lung sounds for adventitious lung sounds, look for evidence of cyanosis, monitor to see that drug therapy is effective, monitor liver function tests, and provide pulmonary therapy as needed. In terms of patient teaching, advise the patient if they experience an allergic reaction to discontinue the medication and notify their healthcare provider. We want to monitor liver function tests periodically. Direct patients not to take St. John's wort without first checking with the healthcare provider because this product may decrease Montelukast concentration. Warn patients that black or green tea taken with Montelukast may cause increased stimulation. Encourage patients to stop smoking. Discuss ways to alleviate anxiety. Advise patients who are severe asthmatics to wear a medical ID bracelet. Encourage patients contemplating pregnancy to seek medical advice before taking Montelukast. Advise patients with known aspirin sensitivity to avoid a bronchoconstrictor response by avoiding aspirin and NSAIDs while taking Montelukast. In regards to self-administration, teach patients not to use Montelukast for reversal of acute asthmatic attacks. Again, this is not an emergency type medication. Advise patients to continue the use of usual regimen of inhaled prophylaxis and short-acting rescue medications for exercise-induced bronchospasm. Encourage patients to inform healthcare provider if short-acting inhaled bronchodilators are needed more often than usual with Montelukast. Tell patients to comply with medication regimen even during symptom-free periods. Tell patients to take leukotriene receptor antagonists in the evening for maximum effectiveness.